Gente, então, pessoal, eu vou convidar o professor Wolfgang Schlumberger a fazer sua aula de diagnóstico diferencial, então, das miopatias autoimunes, continuando o nosso trabalho. Obrigado. Thanks.
Thank you very much, Carlos. Yeah, again, also, first of all, I would like to thank Carlos for the invitation to this meeting, for organizing this meeting. It's always a pleasure being here in Brazil, and I'm already looking forward to having a caipirinha together with you tonight. So, topic of okay, topic of my talk is laboratory diagnostics in autoimmune myopathies. I would like to give an overview of the associated antibodies mainly. So idiopathic inflammatory myopathy is a rare group of autoimmune diseases which is characterized by inflammation, in some cases necrosis, and this results in muscle weakness and disabilities. Here several typical manifestations are shown. The inflammation does or can affect different organs like heart, lung, skin, and here at the left side we see also typical skin manifestations, Raynaud's phenomenon or Gottron signs, these typical signs at the joints, at the fingers and knees. The idiopathic inflammatory myopathies can be grouped in these different diseases, and this is polymyositis, dermatomyositis, inclusion body myositis, and necrotizing myositis Carlos was just talking about. Just some statistics on these myopathies. Incidence, prevalence is given. Mainly females are affected, as it's often the case in autoimmune diseases. Dermatomyositis, polymyositis can really occur at every age. Even children are affected, but the average age at presentation is above 50 years. Still, and Carlos mentioned that also, diagnostic criteria according to Bohan and Peter from 1975 are often used, and although these diagnostic criteria contain some laboratory testing like muscle enzymes, electromyography, no autoantibodies are included. The simple reason is that most of the autoantibodies associated with myopathies had been described and identified after the criteria were established. So I guess there's really a need for updated criteria. The autoantibodies found in myopathies can be grouped in two different subsets. On the one hand, we have the myositis-specific autoantibodies. These autoantibodies are mainly seen in myopathies, not in other systemic diseases. And then we have the myositis-associated antibodies. These are antibodies also seen in myopathies, but also in different other systemic rheumatic diseases. This is a group of the anti-aminoacyl tRNA synthetases. Up to now, we know 8 different enzymes listed here, and the function of these enzymes is to link a particular amino acid to the corresponding tRNA. These autoantibodies against the aminoacyl tRNA synthetases are found in polymyositis, dermatomyositis, and then also a special subgroup often called antisynthetase syndrome. And the main clinical feature of that syndrome is myositis, polyarthritis, mechanic hands, fever, interstitial lung disease, and Raynaud's phenomenon. The most prevalent antibody against tRNA synthetases is Jo1. This is histidyl tRNA synthetase. Prevalence in polymyositis, dermatomyositis is up to 24% described. It's often seen also associated with the interstitial pulmonary fibrosis. 70% of this subset have anti-Jo1. The prevalence of all the other anti-tRNA synthetases can be up to 5% each, but collectively occurring in approximately 6 to 12%. This is the immunofluorescence picture on HAP2 cells. On the left side here you see a fine granular staining inside the cytoplasm. These enzymes are located in the cytoplasm. This is typically not an anti-nuclear antibody, but we had this discussion in the morning. It's found in the cytoplasm. But one has to be really very careful, because often in immunofluorescence these antibodies can be overlooked. There's often low titers, very faint staining only. So if there is a suspicion for polymyositis, dermatomyositis, have really a closer look inside the cytoplasm. Autoantibodies, other autoantibodies in myopathies which are really specific for myositis are listed here. Me2, SRP, TIF1 gamma, NXP2, MDA5, SAE1. I'm going to show more details on each individual antigen a bit later in the next slides. HMGCR was just explained by Carlos. FHL1 is a relatively new target, just described by Ingrid Lundberg at Karolinska in Sweden. We are currently working on that target antigen, and we have to see some other groups as well, whether we can confirm the data from Karolinska Institute. CN1A, at the end of my talk, I have some slides on that, which is a new marker for inclusion body myositis. So now I'm going through all these individual antigens. Perhaps we do not have to look at each individual feature. I try to summarize it a bit. Me2 is an antigen involved in transcription regulation. It's mainly seen in dermatomyositis patients. Prevalence is also given. The prevalence in adults is much higher than in juvenile dermatomyositis. Anti-Me2 is associated with a more favorable prognosis. Pattern on Me2, this is really an anti-nuclear antibody, the only associated marker which is located in the nucleus. So this is a real ANA. SRP, signal recognition particle, first described in polymyositis patients. It's a cytoplasmic RNP complex. Autoantibodies predominantly recognize just one subunit for the 54 kilodalton, and this signal recognition particle is involved in the recognition transportation of newly synthesized proteins to the endoplasmic reticulum. Clinical association, polymyositis, necrotizing myositis, and this is associated also with a more rapid progressive muscle weakness and severe debilitation. Prevalence in Asian cohorts is higher than in European cohorts, but this also depends really on newer studies, availability of these assays. Cytoplasmic granular staining for anti-SRP, also seen here, but really a differentiation between all the different cytoplasmic antigens just by immunofluorescence is extremely difficult. Immunofluorescence cytoplasmic fine granular staining points to these kind of target antigens. MDA5, first described in clinically amyopathic dermatomyositis patients. These are patients which have skin manifestations, but muscle involvement is not seen, is not obvious, or it's extremely weak. So they are classified as clinically amyopathic dermatomyositis. This is a clinical association, and also these antibodies are found in interstitial lung disease. It took some years to identify really the target, and here you see the name of the target. Originally described also in Japanese patients, the prevalence in Asian cohorts is much higher than in European cohorts. Sometimes it's not found, but in some other studies, these antibodies are also found in European cohorts. NXP2, first described in juvenile dermatomyositis. The antigen has been identified just 10 years later. Protein involved in transcriptional regulation. Prevalence in juvenile dermatomyositis higher than in adults. And clinical association, dermatomyositis, calcinosis, and that's also important. I showed just 2-3 slides on that. Also linked to malignancies. Malignancies are quite often seen in idiopathic inflammatory myopathies. TIF1 gamma, first described as P155, P140, still often seen in the literature. The 155 A kilodalton target antigen was identified as TIF1 gamma, 140 kilodalton is TIF1 alpha. A clinical association is dermatomyositis and more severe cutaneous involvement. Prevalence is given, and also anti-TIF1 gamma is significantly correlated to cancer-associated myositis. I have also one slide on that feature. SAE1, SAE2, sumo-activating enzyme subunit 1 and 2 was described by the group of Neil McHugh in Bath. This antigen is involved in post-translational protein modifications, clinical association dermatomyositis. It's never found so far in polymyositis, prevalence 6 to 8%. In our assays, we are just using the SAE1 subunit because so far we have not found a single case which had exclusively antibodies against SAE2, so SAE1 is sufficient. Prevalence of the different myositis-specific antibodies are shown in this table. Important is to note that the prevalence of all autoantibodies together is up to 60%. Usually they are not seen together. It's just one particular antibody and the others are negative. Now I'm coming to autoantibodies associated to myopathies. So these are not specific targets. These are anti-SSA, Rho60, anti-Rho52, PMSCL, KU, and U1-NRNP. These are known to be associated with polydermatomyositis, and I'm just touching two of them. This is the SSA antigen. SSA is a complex of RNA with two different proteins, and this is the SSA protein. The native protein is just a 60 kilodalton. This is really an integral part of the SSA complex. Rho52 is attached, and some claim that Rho52 is not SSA. We are also in our SSA assays, we are not using Rho52 because it's quite unspecific. I'm showing data on that. This is the immunofluorescence on HEP2 cells, a granular pattern or speckled. Today I learned even from my colleague that speckled in Japan means completely different things, but that's why we have ICAP. So these are the prevalences with our assays for anti-SSA, SSB. Anti-SSA antibodies are quite often seen in Sjögren's syndrome, in systemic lupus erythematosus. You see here the prevalences. But these are not really highly specific markers for Sjögren or lupus. We can also see them in systemic sclerosis, polymyositis, of course, it's associated, rheumatoid arthritis, even in healthy blood donors, but of course very low prevalence. In this assay, Rho52 is not included. And Rho52 was once, in that publication, it was described in the title, Rho52 is a marker in connective tissue disease. And then 1,727 samples were tested. Only 1% was exclusively anti-Rho52. And then a further analysis showed that anti-Rho52 can be also seen in different other diseases. So anti-Rho52 is not specific for a particular disease. It lowers the specificity even for anti-SSA, Rho60 for connective tissue diseases. However, Rho52 is quite often associated with polymyositis. It's not a specific marker, but often seen, and it shows immunological processes. And here are different studies on Rho52, and you see the prevalence in every study. Let's say it's between 20 to 30% in polymyositis associated with anti-Rho52. PMSCL is a nucleolar exosome complex comprising different proteins. Main target antigens is the 100 kilodalton protein, but also 75 kilodalton protein can be targeted by the antibodies. So we use in some assays a combination of both antigens in parallel. It's probably involved in the maturation of ribosomal RNA, and these antibodies are seen in systemic sclerosis, polymyositis, and the overlap syndromes between the two diseases. Immunofluorescence pattern, very clear nucleolar pattern, if they are relevant, high titer, so very easily to identify. But it's not the only target antigen for a nucleolar pattern. PMSCL is just one of them. I'm just showing one slide on that. This was a study together with Professor Riemekasten from the Charité in Berlin. We studied overlap syndrome patients, antibodies against PMSCL75 exclusively, just one. PMSCL100 is the main target, but also in overlaps we see anti-SCL70 and anti-centromere B proteins. So here's the prevalence is combined, both targets together, around 25%. Hit rate for all 4 antibodies, 36% in the overlap syndrome. I already mentioned that there's almost no overlap between the antibodies. So if antibodies against Me2 are seen, you rarely see Jo1 or the others. So it really makes sense to test all these antibodies in parallel. And in recent years, we have identified more and more target antigens in myopathies. So the best idea to check for these antibodies is a multiplexed assay. So we launched these Eurolines. These are membrane-based assays where we can combine different target antigens associated with myopathies. The most extensive Euroline is this one here. So you have a combination of all relevant target antigens I just described. And we are right now working on these 3 additional anti-tRNA synthetases that will be added also very soon to the Euroline for idiopathic inflammatory myopathies. Some evaluation data on the Euroline, so I guess it makes no sense now to go to each individual target, and this is the prevalence and this is the specificity. That has been, for example, tested by Johan Rönnelid from Sweden. Serological hit rate with all antigens was 26% in that study. This is a study from Anna Girardello in Italy, and she found a serological hit rate of all combined target antigens 37%. Another publication from Cavazzana, also in Italy, he found a quite high serological hit rate, so there are sometimes discrepancies between different cohorts. We do not know exactly the reason, but this is just a phenomenon seen in different studies. Concordance to immunoprecipitation was 77%. We still have some targets where the correlation to immunoprecipitation is not 100%, but there may be also some doubts whether immunoprecipitation just detects one target. It may be a complex of different targets, so that's a reason for some discrepancies between these methods. Another evaluation Giuliani presented at the Dresden autoimmune meeting, also different targets were associated. He was more interested in a patient stratification, not just what is the serological hit rate, but can the target antigens or the antibodies also be used for certain clinical manifestations in the patients. And what they described that is that anti-Jo1 is associated with severe interstitial lung disease, whereas anti-Me2, anti-SRP, anti-TIF1 gamma are negatively associated. So what about malignancy in myositis? That is a known phenomenon since quite a long time. Some facts on that. There's a known association. The risk is greater in dermatomyositis than in polymyositis. Association is shown with several cancer types. And in large population-based cohort studies, a prevalence of 20 to 25% of patients having malignancies was reported. And although the risk rises with age, all adult patients should be screened for tumors because there's really such a high association. That is a study from Lancet, also evaluating a large number of polymyositis, dermatomyositis patients. And it was shown that 15% of polymyositis patients had cancer, 32% of dermatomyositis. So risk in dermatomyositis is higher, but it can be occur in all myopathies. Interestingly enough is that 69% of cancers and 58% of cancers developed after the diagnosis of dermato or polymyositis. So this is really the diagnosis of myopathies should trigger tumor screening. TIF1 gamma positive dermatomyositis patients have significantly more internal malignancies than anti-TIF1 gamma negative patients. So the difference is really quite significant, 58% versus 9%. So even here the autoantibodies, the positivity of autoantibodies point to a certain direction. Now my last few topics about inclusion body myositis. This is an inflammatory myopathy characterized by both degenerative and autoimmune features, acquired muscle weakness, the presence of inflammatory infiltrates in skeletal muscle tissue. It represents the most commonly acquired muscle disease in people aged above 45 years. And in contrast to polymyositis, inclusion body myositis is poorly responsive to treatment, including immune modulation. The diagnosis is mainly based on clinical presentation and histological findings in muscle biopsy. But the histological findings are not always clear, so there is often a necessity for multiple biopsies. It's also often a clinical, very similar clinical presentation to polymyositis. Up to 50% of the patients with inclusion body myositis are not really finally diagnosed within the first years. Often the final diagnosis is delayed up to 8 years. So in the early stages, it's extremely difficult to differentiate between polymyositis and inclusion body myositis. But there is now a new antibody found in that disease, in inclusion body myositis, CN1A, just recently, and we recently launched the first commercially available assay. So this may be a bit a game changer in all these difficult cases. It's worth to test for these autoantibodies. It has been identified as cytosolic nucleotidase 1A. It's a protein abundant in muscles. It's involved in nucleotide metabolism, and in several publications you can still find that name, MUP44. That was the original name for 44 kilodalton protein before the real target was identified. So we developed an ELISA based on a full-length CN1A. We have a relatively high specificity, above 96% in both studies so far done. Sensitivity is moderate, just in the range, let's say 1/3 of the patients have these autoantibodies. We all wish prevalence would be 90%, even 100% would be better, but in any case, in 1/3 of the patient, there is an autoantibody which really points to inclusion body myositis. So this is possible. What we currently do not know, whether patient stratification is possible. What about those patients having the antibody? Are there certain clinical manifestations? All this should be studied in further evaluation, should be analyzed in further evaluations. I just show you here the study results. One cohort was from Geerpoin, from the Netherlands, who first identified that marker more or less at the same time as Greenberg in the United States. So in his laboratory we had a sensitivity or prevalence of antibodies of 39%. Specificity was only checked with healthy blood donors, 96%. And this was a study just recently performed at RDL in Los Angeles, and we just published it and got the notification last week. Prevalence in that cohort was 35%, so you see pretty much the same. Specificity, very reasonable. We could not find the antibodies in polymyositis, dermatomyositis, but the numbers are low. Also interesting was Sjögren's syndrome, 100% specificity in these 20 samples. There was a publication from a group in the United States using an in-house assay, and they found up to 30%, 40% positivity in Sjögren's syndrome, but that could not be confirmed, at least with our assay, which is commercially available. Just acknowledgement, many people are involved in all these data. I summarized just in 15 minutes, ongoing process since many years. And I'd like to thank you for your attention. And this is, just to mention it, this is my hometown, Lübeck, where also the company Euroimmun is located. This is a gate to the old town from 1450 something, so the landmark of that city. Thank you very much.